Hi everybody, welcome to my YouTube channel Dr. Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. Today we are going to talk about a very important topic, the pain. The pain, in fact, it is the most common symptom for which a patient approaches the doctor. Pain and the indispensable concepts. What are all the important and indispensable concepts of pain we need to know? Here we go. Pain. Pain actually is an unpleasant sensation localized to a part of the body. It is an unpleasant sensation localized to a part of the body. Pain actually has got a duality. It has got an perception of the pain where we appreciate the intensity of the painful stimulus, that is the sensation, and second, it has got an emotional component to it. Not all persons with equal intensity of pain react in the same manner. For example, persons who are trained in army, who are exposed to difficult conditions, may be able to withstand the same amount and intensity of pain better than a person who is raised in a sophisticated environment. So pain has got duality. It has got two components. One, the actual perception or the actual sensation of pain. Second, the emotional component of pain. The actual sensation or the perception of sensation of pain is analyzed by the somatosensory cortex. From the thalamus, the fibers goes to the somatosensory cortex where it analyzes the perception or the intensity of the pain. Not all fibers from thalamus go to the somatosensory cortex for the appreciation or the perception of sensation of pain. Few fibers goes to the insular cortex and the cingulate cortex. So these fibers are responsible for the emotional reaction to the pain. So given the same intensity of pain, different people react in a different manner according to their emotional component. So pain has got two functions. One, the perception of the pain. Second, the emotional reaction to the pain. The perception of the pain goes from the thalamus to the somatosensory cortex to the spinothalamic tract. And the emotional reactivity to pain goes from the thalamus to the cingulate cortex and the insular cortex. Right. The understanding of pain can be divided into two subheadings. One, the peripheral mechanisms. Second, the central mechanisms. First, let's see the peripheral mechanisms. To understand the peripheral mechanisms, we need to understand the components of a peripheral nerve. Obviously, any painful stimulus, for that matter, any sensation has to go to the peripheral nerve. So, a peripheral nerve basically has got three important components. One, the primary sensory afferents, wherein the sensations are perceived. It could be touch, pain or temperature. Second is the motor neurons, where the strength or the power to perform a motor act is done. Third is the sympathetic postganglionic neurons, which are responsible for the autonomic activity. So we have three important components: the primary sensory afferents, the motor neurons and the sympathetic postganglionic neurons. Very important, the primary sensory afferents are divided into three subheadings or subcomponents, namely A beta, A delta and C fibers, depending upon three important components. One, depending on the diameter, depending on the myelination and depending on the conduction velocity. The A beta fibers are well myelinated fiber, very large fibers, and obviously because they are well myelinated, the conduction velocity is very rapid. So A beta fibers are the largest fibers, well myelinated fibers, and conduct velocity at a very rapid speed, and these are the A beta fibers which are responsible for the light touch and moving stimulus. That is, these large fibers carry out the function of the posterior column, light touch and the moving stimulus. So they are well myelinated, large fibers and have a rapid conduction velocity. The second is the A delta fibers. They are small fibers, less myelinated, and conduction velocity is also slowed. So these are known as A delta fibers. And finally we have C fibers, which are totally unmyelinated. These A delta fibers and C fibers, which are small fibers, less myelinated and conduct velocity slowly, are called as the pain perceptors, pain receptors, and they respond to painful stimuli. So these are the small fibers, carry the pain and temperature sensation as like the spinothalamic tract. So these are known as primary afferent nociceptors. Very important concept is that cornea does not have the A beta or large fibers. There are no touch fibers. They have only A delta and C fibers, which are responsible for pain. Perhaps Mother Nature wants to give lot of protection to the eye, because eye is very important, and therefore any stimulus which comes and touches cornea, it does not become a touch sensation. It goes to the pain receptors and become a painful stimulus, so that we avoid the traumatic stimulus. So cornea does not have touch receptors. They have only the pain receptors, that is A delta and C fibers. Very important. So when we do corneal reflex, we are not trying to elicit the touch sensation but the pain perception. Again, I repeat, very important, primary sensory afferents can be divided into large fibers and small fibers. Large fibers are large, well myelinated, they conduct velocity at a rapid speed. They are like posterior column, carry the light touch, position, joint and vibration sense. The small fibers, as the name suggests, are small in size, less myelinated, conduct velocity very slowly. They are akin to the spinothalamic tract fibers. They carry pain and temperature sensation, which includes A delta and C fibers. Very, very important concept. And the peripheral nerve also contains the motor neurons and sympathetic postganglionic neurons, which are unmyelinated. Right. These are the components of a peripheral nerve. Now let's see pain, the different types of pain. The different types of pain are: one, the somatic, which is perceived at the level of the skin, bones, joints, muscles. Second is the visceral pain, which is perceived from the visceral structures. Third is the neuropathic pain, which is perceived at the level of the damage of the nerve fibers, which includes also causalgia, that is the nerves which also acquire adrenergic sensitivity. So we have a somatic, visceral and a neuropathic type of pain. Somatic type of pain is perceived from the skin, joints and muscles. Here the nociceptive stimulus is very much evident. An injury might have taken to the muscle or the joints or the skin, and it is well localized. They can pinpoint and say where exactly the pain is. The treatment is NSAIDs, non-steroidal anti-inflammatory agents, and narcotics can also be given. Second is the visceral pain. Visceral pain is from the visceral structures, intestines. They are silent nociceptors. They don't per se perceive the pain, but once the visceral structures get injured or inflamed, then they perceive pain. So per se there is no pain receptors. They are known as silent nociceptors. They don't perceive pain. Only when it is injured or only when there is inflammation do the visceral structures transmit the pain sensation. So they are silent nociceptors. They have A delta and C fibers. They are insensitive to non-injured and non-inflamed tissue. Only when they become injured and inflamed do these structures transmit pain impulses. They are activated by inflammation. like a decreased pH, acidic environment, prostaglandins, substance P or bradykinin or leukotrienes. Only in the presence of these inflammatory mediators do the visceral structures transmit pain. They are poorly localized and they are usually referred. The spatial displacement of the pain from a injured area to the other areas is known as the referred pain. For example, C3, C4, C5, the diaphragm and the shoulder, they go onto the same C3, C4, C5. So if there's an injury or inflammation of the intestine, it may be referred to the shoulder area, which we call it as a referred pain. So referred pain is very common in the visceral type of pain. They usually have discomfort like nausea and vomiting, and the treatment is narcotic analgesics. The third type of pain what we see is neuropathic pain. The neuropathic pain when there is an injury to the nerves, to the spinal cord or the thalamus and its projections. Here there is no obvious nociceptive stimulus. Always remember trigeminal neuralgia or herpes zoster ophthalmicus. These are all types of neuropathic pain. They are associated with the nerve damage, signs like weakness or sensory impairment. The pain of the neuropathic type, the neuropathic pain is typically lancinating or electrical in nature. The treatment what we give for neuropathic pains, unlike the somatic pains where we can give non-steroidal anti-inflammatory agents or narcotics for somatic and visceral pain, here the treatment for neuropathic pain is usually anticonvulsants, sodium channel blockers like carbamazepine, phenytoin, gabapentin or pregabalin. Why we give these anticonvulsants for neuropathic pain? These anticonvulsants are sodium channel blockers. When the nerve gets injured, the demyelinated nerve exposes the sodium ions and therefore it transmits the painful impulse. So by blocking these sodium ions in the damaged nerve, we are prohibiting the transmission of the nerve impulse, and therefore anticonvulsants are very useful in neuropathic type of pain like trigeminal neuralgia where we give carbamazepine or oxcarbamazepine and herpes zoster ophthalmicus. And then we have another type of neuropathic pain which is known as causalgia or CRPS, complex regional pain syndrome, where these damaged primary afferent nociceptors acquire adrenergic activity. They acquire adrenergic activity and can be activated by stimulation of the sympathetic system. So causalgia is a continuous, not a well-defined severe burning pain accompanied by sympathetic nervous system dysfunction in the form of sweating, vascular skin and hair changes. So sympathetic blockade may be helpful in this type of pain, a neuropathic pain, causalgia, complex regional pain syndrome. The other two important concepts we need to know is sensitization. What is sensitization? It refers to a lower threshold. It refers to a threshold being lowered. That means even a small stimulus can produce a painful activity. So it refers to a lower threshold for activating the primary afferent nociceptors following repeated stimulation in the damaged or inflamed tissues. Example, sunburn. When there is sunburn, there is an injury and inflammation of the tissue, and here it becomes sensitive, which refers to a lower threshold producing the painful response. That is known as sensitization. Another important concept lies when we understand sensitization, what we call as allodynia. So sensitization refers to a lower threshold for painful stimulus. So allodynia is following injury and resultant sensitization. Normally innocuous, normally non-painful stimulus may become painful. We call that as allodynia. So these are all the peripheral mechanisms to understand the pain. What are the central mechanisms to understand pain? To understand the central mechanism, we need to understand two important pathways. The pain transmission pathway, which transmits pain, and the pain modulation pathway, which modulates the painful perception. The pain transmission pathway is an ascending pathway coming on from the receptors, going on to the dorsal ganglia and to the spinal cord, wherein after one or two segments it goes to the opposite side and crosses over as a spinothalamic tract, ascends to the thalamus. From thalamus it may take two routes. One, it goes to the somatosensory cortex where the perception of the pain occurs, where the pain is perceived, the intensity of the pain is perceived. Two, it goes to the frontal cortex, cingulate, the insula and the cingulate, where the emotional aspects of the pain is perceived. So if there is a frontal lobectomy or the frontal cortex is damaged, an emotional reaction to the pain may be diminished, but the perception of the pain is present. So this is a very important concept. Pain is duality. Pain has got dual components. One, the actual perception of the pain. Second, the emotional reaction to the pain. The actual perception of the pain is done by the somatosensory cortex. The emotional aspects of the pain is done by the cingulate as well as the anterior cingulate as well as the frontal insula. Right. This is the pain transmission pathway which uses serotonin, norepinephrine and other neuropeptides for neurotransmission. And therefore, when you increase serotonin and norepinephrine, the pain decreases. In fact, this is the way the tricyclic antidepressants act. They enhance the serotonin level and norepinephrine level, by which the pain perception decreases because of the decreased transmission in the neurotransmission pathway. Right, this is about the pain transmission pathway. Then we have another pathway which is known as pain modulation pathway. Pain transmission pathway is an ascending pathway, the spinothalamic tract, going on from the sensory receptors to the thalamus, to either the somatosensory cortex or the insular and cingulate. Then we have the pain modulation pathway, which is a descending pathway, the bulbospinal pathways coming from the hypothalamus, midbrain and medulla oblongata, and modulate these pain transmission through the pain transmission pathways. So here the opioid receptors, especially the mu receptors, are present in a big way in the pain modulation pathway, and therefore narcotics act through the pain modulation pathway by enhancing the activity of mu receptors and therefore decreasing the pain perception. So narcotics act on the pain modulation pathway by increasing the narcotic activity through the narcotic receptors, that is mu receptors, and therefore decreasing the pain perception. The pain modulation pathway not only decreases the pain like opioids, which is known, and sometimes placebo effect, telling the person your pain is going to come down, your pain is going to come down, the pain comes down, or giving a tablet which is not an analgesic and telling him that the pain is going to come down, the pain is going to come down. This is known as placebo effect. This adds to the pain modulation pathway and decreases the pain transmission. Not only it decreases the pain, sometimes it can even enhance the pain. The pain modulatory pathway may act on the pain transmission pathway and may enhance pain also, like migraine. In migraine, the pain modulating pathway is activated. There is an enhancement of pain. So even a psychogenic conditions or lot of tension can propagate or can make the pain occur. Example, migraine, which is called as a nociceptive effect. Finally, we have referred pain. As I said, the pain referred from a spatial displacement of the pain from the injured area to the non-injured area. Example, C3, C4, C5, the viscera, the pain getting referred from the diaphragm to the shoulder. So what is the treatment of pain? Finally, the patient is concerned for the treatment of the pain. We've talked so many concepts of pain, but from the patient point of view, the treatment of pain is essential. The pain has got two important conditions. One, it gives you an unpleasant nature. So patient wants to get relieved of the pain and therefore approaches the doctor for treatment and control of pain. And second, a very important point, an important concept is that pain is produced so as to make the person understand that there is some bodily part is disordered. So the treatment of pain, basically there are four types of treatment. One is NSAIDs, non-steroidal anti-inflammatory drugs, example diclofenac. Second is the narcotics, example morphine. Third is the tricyclic antidepressants like amitriptyline. Fourth is the anticonvulsants like carbamazepine. How do these drugs act? The first kind of treatment, non-steroidal anti-inflammatory agents, inhibit the cyclooxygenase and prostaglandins, and therefore they reduce the tissue inflammation. Example diclofenac. Narcotics morphine, they enhance the modulation through the pain modulation pathway to the mu receptors. We have the descending pain modulation. So the narcotics act on these descending pain modulation pathway, acting on the mu receptors and therefore decreasing the pain perception. Antidepressants like amitriptyline, they enhance the serotonin level and the norepinephrine level, and therefore the pain transmission pathway gets affected and the pain perception gets decreased. And finally, we have anticonvulsants like carbamazepine, which are sodium channel blockers, which block the sensitivity and enhanced activity of the damaged peripheral nerve where the sodium channels are exposed, thereby limiting the spread of the painful stimulus from sodium channels from one area to the other area. So these are all the four types of pharmacological treatment we can offer to the person who's suffering from pain. One is the non-steroidal anti-inflammatory agents like diclofenac, narcotics like morphine, tricyclic antidepressants like amitriptyline, and anticonvulsants like carbamazepine. These are all the essential and fundamental concepts of pain. These are the indispensable concepts of pain, and everyone needs to understand all these concepts of pain. I hope you have enjoyed listening to my lecture. If you have any suggestions or comments, kindly post onto my YouTube channel. But please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.